Thank you very much indeed for coming along this morning. And for the intro, Angus McAlister is the name. I lead a solutions architecture team okay, is that better on the mic front?
Turn your microphone on that we gave you.
Okay, it's on. Yep, it's certainly on there. Okay, right. Thank you. Apologies for that. So I look after a solutions architecture team in the UK, which focuses specifically on healthcare. And Joel asked me to come along today to share a few stories from the UK, and hopefully some of those will be relevant to yourselves. Right, so our agenda for today is 5 things. Firstly, a quick overview of the UK's National Health Service, for those of you not that familiar with it. Secondly, the challenges and opportunities that the NHS itself faces, which will also be familiar to many of those in the room. Thirdly, what the role of technology will be in addressing those challenges with regard to health outcomes and associated topics. Then the good stuff around what specific customers have actually managed to achieve and are doing using cloud to aim at those outcomes. And then finally, any good presentation of this nature has a call to action. So we'll get to that at the end. Right, so let's do an overview of the NHS. The National Health Service in the UK is a fairly complex beast, but I've tried to simplify that as much as possible to avoid overwhelming you with irrelevant information. But roughly, this is how it's set up. So it starts out with the Department of Health and Social Care at the top, allied with the Public Health England, and beneath that, you could layer it into 3 different things. The services that need to be provided, the organizations that provide those services, and then the orgs that commission those services. The top-level commissioners are NHS England, underneath the Department for Health and Social Care, and then with regard to public health, local government is responsible for commissioning that. For primary, secondary, and mental health, clinical commissioning groups are consortia of GP surgeries and similar organizations which then have funding devolved to them and who actually make the local decisions about what services are required in a given geographic area. So not surprisingly, the services that they specifically focus on are primary, secondary, and mental health. And then under public health, they not only public health generally, but also social care in particular is a responsibility of local government, and local government organizations do commission that. The orgs, not surprisingly, that provide primary, secondary, and mental health are GPs, what are termed acute trusts and mental health trusts. Supporting them are ambulance trusts and community trusts. And then in support of social care are either private providers who actually bid for contracts to offer that, and non-profit organizations. Topping that up are a variety of other national bodies which don't necessarily fit into the precise structure we've got here, but are important for digital health and ultimate outcomes. And those are, firstly, the Care Quality Commission, which is there to enforce standards of clinical healthcare and social care. Then NHS Improvement, which is predominantly focused on efficiency, although its remit is gradually widening. And then 2 other organizations, if I can get this pointer working, NHS Digital and NHSX, which are probably of the greatest interest for people in this room in the sense that they've got responsibility for things like national applications, clinical data standards, the routing of innovation funding, etc., to bring about changes to digital healthcare. So more on those orgs in a moment. So let's move on to challenges and opportunities for the NHS overall. These are going to be similar to many Western health systems. The old chestnut of aging populations, which is a real issue for G20 countries, and which to many looks like a slow exploding bomb, which we need to do something about. Another thing which affects more than just the G20, a long litany of chronic and expensive to treat conditions such as diabetes, increasing range of cancers, neurodegenerative diseases such as Alzheimer's and Parkinson's, etc. Mental health is increasingly an issue, particularly in the West, and so these are imposing a really huge burden upon the NHS and are really driving the need for change. Since 2010, following the global financial crisis, the NHS has had to contend with real terms budget reductions. So whilst it's been partially insulated from the drastic austerity measures undertaken in the UK since then, it's still not been immune from that. And the relentless focus on efficiency, so the UK spends approximately 9% of its GDP on healthcare, which I guess is reasonably good by G20 standards, is probably insufficient. And so that's also been quite a big thing to have to contend with. On the bottom left-hand side there, a thing that's driven many of the decisions and the behavior within healthcare overall and within digital healthcare in particular has been the paramount need to maintain public trust, because that's very, very difficult to earn and very easy to lose, as has been discovered with some of the projects in recent years. Similar to many other healthcare systems, it has a very risk-averse culture too, because nobody wants to rock the boat in case they themselves end up in the limelight for the wrong sort of reasons. And that actually militates quite strongly against the broader application of innovation. One of the outcomes from that is that because of the risk aversion around innovation, that's meant that the data supporting health and care has actually remained in some quite difficult to access silos, and breaking those silos down in order to get access to those data has encountered a lot of headwinds from people who've got concerns about privacy and security and about the effect of change generally. And then finally, as a result of the things coming to a bit of a grinding halt with the austerity program following the global financial crisis, a great many of the IT-related contracts within the healthcare world in the UK have served to slow innovation down as well, and have meant that the technology that exists within the NHS is in many cases very outdated indeed. Just by way of example, until very recently indeed, the means of patient referral from primary to secondary care was largely by fax, and even in existing hospitals today, referrals between departments often occurs by fax. And the NHS is Europe's largest purchaser of fax machines. So that is something that definitely needs addressing. The impacts of those challenges are fourfold in the main. So because of the fragmented and quite specialized technology that's in use, and the fact that it's so old, that really limits the opportunities for the NHS to take advantage of the economies of scale that would arise from that. In a big healthcare system of 67 million people, that's a real missed opportunity there. As a result of that, digitalization is quite slow to take hold in those parts of the NHS which are less well served by technology, and so that acts as a brake on innovation too. That then has the corresponding impact of data transmission delays, getting data between primary and secondary care, for example, say for emergency treatment or for some quite specific decision-making within a secondary context is difficult. And that has then had some implications for patient safety. So there was a recent study done demonstrating that the lack of data mobility within the system has actually had negative effects on patient outcomes, and that's demonstrably the case. Happily, there are some assets the NHS has in its favor to be able to change all this, and some opportunities that therefore arise from that. So the first is a large genomic data set. So you may have heard of the 100,000 Genomes Project, which was something undertaken some years ago to try and collect the whole genomes of people with rare diseases, firstly to foster accelerated research on that, to bring about a more personalized approach to medicine for individuals suffering from rare diseases. But because of the success of gathering those data and the rich source of rich repository it represents for doing that kind of research, it's also meant that people with rare diseases have actually had improved outcomes as a result of some of the studies that have been done and new therapies that have been introduced. And so there are plans to extend that quite considerably and sequence a much larger number of people's genomes in the years to come to serve healthcare. Throughout the US, the NHS, there's been a strong emphasis over the years on standardizing terminologies. So I don't think it's as a particularly major challenge here in Australia or in surrounding countries. I know that in the US, standardizing on terminologies has been a real issue. So semantic interoperability has been incredibly difficult to do. So at least that's not something that the NHS has to worry too much about, given the wide adoption of those standards. On the top right, the fact that we've got bodies in whose primary remit is a focus on digitalization of healthcare and of fostering innovation is a positive, and does help to swim against the tide of inertia that I was describing in the previous slide. And then finally, because of the large number of clinicians who are actually feeling the pain of this at grassroots level, and many of them have actually taken it upon themselves to become technology literate too, and either collaborate with or even establish startups to be able to start tackling some of these things at the coalface, as it were. So that means it starts to put the NHS in a position to take advantage of these opportunities here. So the first of those is a really top-of-mind subject for an awful lot of healthcare systems who are trying to integrate and digitalize, and that is around interoperability standards. So FHIR is the latest evolution of that, building on HL7, V2 and V3, and shows a lot of promise. Yes, it's complex, and there's a lot of work still to be done, but there's a lot of optimism as well as to what that can actually deliver in terms of improving the flows of data within the healthcare system there. The next one down here, to be able to get faster feedback from interventions. This has been a real challenge in the healthcare world, to be able to do that translational research. Very often, for a given change to accumulate enough evidential data to support a more widespread rollout of that, that can take up to 15 years in some cases, and especially for patients who have conditions that are life-threatening in a shorter period than that, that has very negative outcomes indeed. So being able to shorten that feedback loop and to be able to identify the effects, positive or negative, of any interventions much earlier is something that will help improve those outcomes much quicker. That's a challenging beast, but it is definitely an opportunity to be pursued. And then ultimately the magic trio, the 3 Ps of care, preventative, so helping patients be responsible or play a very active part in the management of their own health, and therefore bring that, or make use of the digitalization of healthcare so that they can actually prevent themselves developing conditions or postpone that happening is vital. And then for individual clinicians, so GPs or others involved in the care of patients, to be able to gather sufficient data around individual patients to predict whether they're going to suffer from any life-threatening or lifestyle-threatening conditions, which also may then have a very expensive impact on the healthcare system that they are part of, is an essential part of actually bringing down the cost of healthcare and making it more sustainable. And then finally, personalization, to be able to ensure that each intervention or each measure that's there to prevent healthcare, negative healthcare events is specific to each individual patient. So that's a long way off, but it is achievable. And so it's one of the stated goals of NHS's technology to be able to bring that about. So let's move on to what the role of technology will actually be in this. So there are 4 guiding principles that NHS has actually established to enable technology to be effective here. And the first of those is almost self-evident. So user need. Well, obviously, surely you should design systems which actually satisfy user need. You'll be bitterly disappointed and negatively surprised to learn how much has actually been done without taking that into account. So it's been more about putting a square system peg into a round hole. And not surprisingly, that's seen limited adoption and uptake, and therefore limited positive effect on patient outcomes. So having that as a foundational principle for the use of technology in the digitalization of healthcare is absolutely essential. So I was very gratified to see that is an important thing now to the NHS. Interoperability and openness, I think that almost goes without saying. Enabling those data flows to ensure that clinicians have a much richer picture of a patient's health, enabling each individual patient to have greater visibility over their own health record and what effect that will have on their own health is the way to keep them more engaged. Because of the need to maintain public trust, privacy and security continue to be absolutely essential, and so that receives equal attention in this set of principles. And finally, inclusion. Whilst the temptation is, when designing healthcare technology, to make it appealing to millennials who are smartphone first, and they do their banking online, so why not all the healthcare online? We need to recognize that there's a full spectrum of people in terms of their not only their access to digital technologies, but also their capability to make use of them. And so the NHS is very, very strongly emphasizing not leaving anybody behind in this respect. Okay, so supporting those guiding principles are these architectural principles. And I'm happy to say this is the only slide with actual bullet points on it. I tried to spare you bullets as much as possible in putting this together. So technologically, what they are focusing on is the following. So instead of, at the client end, having legacy systems which depended on heavyweight, thick client Win32 applications, there's a very strong emphasis on actually making this mobile first in the browser. There's strong emphasis also on doing everything internet first. So if it's no longer hiding behind the false sense of security of an external network with just a single layer of security. If having services accessed over the internet forces people to think much more carefully about how they layer security and make that work for patients. Cloud first is something that they've also very strongly emphasized. They've recognized that it's only really feasible for a hyperscale cloud provider to have the resources available to bring about the economies of scale to enable NHS organizations and the innovators who work with them to have access to the security and compliance measures that otherwise would be out of their reach. With regard to data, they've wanted to take the approach of having distributed data registers rather than a huge centralized repository, and have those data accessible over APIs using FHIR as the interop standard for that. And that basically reduces the attractiveness of those targets for hackers, rather than having a big juicy honeypot for them to go after. Security, I need to say no more about there, but the separate layers of the stack there is about compartmentalizing the different technology areas such that it's much easier to swap in and out different providers based on the effectiveness of those solutions, rather than having NHS organizations locked into long-term contracts. Okay, so let's move on to the meat of what you came here for, what customers are actually doing there. And I realize that I've run slightly over time here, so I'm going to have to go through this a little faster than I expected. But I would very much invite questions afterwards if there's more that you'd like to know. So the first of these is a collaboration of organizations called One Gloucestershire, who are working with an AWS partner called Kanos to bring together healthcare records in the county of Gloucestershire. And so this is through a system called JUI, or joining up your information, which entails the organization types on the left being able to share data and bring those all together so that clinicians can actually have a single view of the patient across multiple repositories of clinical data that are relevant to them. And by the numbers, this is how that is played out, that it covers about 600,000 patients in that area. It entails 8 organizations that are working together for this, and this system is getting around about 4,500 views a month, which shows that engagement is pretty strong. I'll just give you a moment to read this quote by the Chief Clinical Information Officer for the Gloucestershire CCG, which has actually commissioned this. So that helps them in the quest for improving patient outcomes within Gloucestershire. Next one I wanted to share with you was something I think would be particularly relevant to Australian audiences, a company called SkinVision, who have an app of the same name, whose function is to enable people to capture images of moles and have those assessed within 30 seconds in the cloud for the risk of skin cancer. So what they do is take various images of the mole, upload that to SkinVision's cloud service. Their machine learning model then evaluates that and gives it an initial risk score. That's then passed on to their dermatologist, who then assess that for accuracy, and then add it to their store of roughly 3 million images, which has actually given them quite a significant training data set to improve the accuracy of the algorithm, which is now actually achieved over 90% of accuracy. So what that then enables is greater, it was one of the goals of digital healthcare, i.e. early detection of potentially life-threatening conditions such as melanoma, which then because of the earlier intervention you can then do, have the probability of being able to extend patient life and improve the outcomes that they will have. The Chief Technology Officer for SkinVision had this to say about the use of cloud for this. And then finally, the National Health Services Business Services Authority, which has the following function. So it's one of the orgs I didn't actually mention on the big slide, but one of the things they do is administer something called the European Health Insurance Card, which basically means that people resident in the UK who travel around Europe can actually access healthcare for free, which is then paid for in the back end by the NHS by the use of this card. Now, they have a contact center which is responsible for handling all the queries around this card, and one of the issues they have is that an awful lot of these queries are very, very repetitive and dull, which meant that they had increasing difficulties with staff engagement and therefore high staff churn, as more people got sick and tired of having to answer the same old questions again and again and moved on. This then had a massive cost impact, and so what they decided to do was actually introduce an automated call center using Amazon Connect. What the solution then also did was make use of a number of machine learning services within the AWS panoply, including Lex and Poly, as well as Lambda and S3 on the back end. And what that then brought about was the following positive impact. So of nearly 11,000 inbound calls during that 4-week period that this proof of concept ran, more than 42% were able to be resolved automatically by the solution that was put in place. There was a marked reduction in staff turnover because now suddenly these people could actually focus on things which were interesting rather than the dull same old. That meant they were able to reduce recruitment costs and training costs. So there was a definite positive cost reduction achieved there. And then finally, because of greater staff engagement, there were significant jumps in customer satisfaction. So And the best news about this is that it took less than 2 weeks to put together this proof of concept and then run it through that 4-week period. So that was deemed to be an enormous success by them, and something which they're then rolling out much more broadly within their organization to achieve similar goals. Okay, so my final slide is our call to action. Your clinical challenges, we really want to hear about those and help you address those. So please do engage one of your AWS contacts to actually talk about this in more detail, and or an AWS partner to help you address those. This is about helping you fix the challenges which you've got. And don't be afraid to think big. That's all from me today. Thank you very much for your engagement, and I hope to speak to you later on today. Yeah.